Evening, everyone, and welcome to our Centre for Perioperative Care webinar on anemia, following on really from the publication of our new guideline on perioperative care for people living with anemia. So we're just giving everybody a chance to log on and get going. So we were just going to give everybody a minute or two. We know we've got a lot of people signed up for this evening. So hopefully everyone's just getting in, getting a cup of tea, or at work getting a cup of tea, and then we'll get started in the next couple of minutes. Just while we are getting started, just a reminder to everybody to have be on mute, have your cameras off, and if you do have questions, which we are really keen that you do have questions, do remember to pop those in the Q&A. And we'll come to those at about 7:10 following the presentations that we have lined up for you this evening. So I'm really pleased to be inviting Scarlett to kick off this evening's session. So many of you will know Professor Scarlett McNally, who's an orthopaedic surgeon in Eastbourne, but Deputy Director at CPOC, where we have lots of fun working together. She's also a previous council member of the Royal College of Surgeons and has worked very hard on this guideline together with lots of others from the team, and is going to kick off by presenting the key aspects of the guideline. So over to you, Scarlett. Thank you.
Thank you very much. And I'm just going to share some slides. Bear with me a moment. Okay, so these slides will be available afterwards. They're quite crowded because people will be able to watch them through again on the recording or look at them to get detail. So it is a whistle-stop tour. So this is about the new Pre-Operative Management of Anemia guideline. And it's from CPOC, and anyone who doesn't sign up for our newsletters already, please do so. Look at cpoc.org.uk, send your patients and your colleagues there. We've got all sorts of things if you look in the search button, including this anemia guideline. Perioperative care is from the moment surgery is contemplated until full recovery. And CPOC is really amazingly credible. We have a number of partner organisations that are very well respected, and a large network of clinical leads, one in most of the UK acute hospitals, and an advisory group, including charities and patient groups that reaches thousands. So the Anemia Writing Group had a large number of organisations on it, for which we're very grateful, and it was lovely working together with people from different ways of looking at patient issues. So here it is, the guideline for the management of anemia in the perioperative pathway, and you can find it on the CPOC if you just put anemia into the search bit of the website. And when you get there, you don't just find the guideline, you find lots of things. Alice, the CPOC coordinator, has dissected into multiple things. So there's a page for patients, or a page for the standard of care. So you can get those things separately, or the whole guideline should you wish it, and the algorithms if you want to take them out, print them, put them on the wall. So starting with this as the summary of the standards that are expected. And it's beautiful, and I've just got the list of them here. So it's basically, it's about getting the whole pathway to work better. So everyone should develop pathways across from before surgery and after. Data should be collected, and audits of practice using that. The big thing is a full blood count should be done early at the referral to surgery if there's an expected blood loss of 500 mils or equivalent in children, 10% of blood volume. And children if there's 10% risk of transfusion. And then if there is anemia, there should be documentation of the type and the cause of the anemia. And if there's anemia, there should be a plan for the patient blood management. the patient should be given information and staff should have training. So that's basically it in a nutshell. You might think, haven't we got enough guidelines already? And you know that NICE has a guideline on NG45 on blood tests, there's NG24 on blood transfusion, there's all of these guidelines. But basically what we've done at the Centre for Peroperative Care is we've brought them all together, because otherwise they were known about by one group of staff or in one specialty, but not really well known in others. So ours includes all of them across the whole pathway. But actually anemia should be seen as a serious and treatable medical condition rather than just an abnormal laboratory value. So it isn't just measure it and write it down, it's measure it, work out what's causing it, do something about it, talk to the patient, with the patient, and make a plan. And obviously I've put this in because blood transfusion can still be life-saving and there is still a place for blood transfusion. So what we've got in the guideline, well, we start with recommendations, and there are recommendations for a large number of people, recommendations for people working in staff working in the operating theatre, recommendations for patients, recommendations for commissioners and organisers of services and so forth. And then there's a big chunk of explanation and evidence and treatments and a discussion about the types of anaemia. And it is really educational, and it explains things very clearly, and there's some beautiful charts and flow charts and things. So do give it to everyone, because it explains the bit that is slightly outside your comfort zone, if you see what I mean, across the whole pathway. And then we've got algorithms, and we've got a section on pregnancy and a section on children. So what is the evidence? And in fact, we looked through there's 131 references quoted, but we looked through a much wider literature so that we're giving the latest evidence-based recommendations. And 1/3 of people are anemic before major surgery, and major surgery being defined as 500 mils blood loss or 10% blood volume. If someone's anemic, they have 2 or 3 times the rate of complications. Now, some of that is because they've got other things going on as well. But as an independent risk factor, it increases the risk of complications by about 20%, perhaps. And again, there are risks of blood transfusion, particularly around immunity and exposure to donors and affecting future cancer risk and problems with pregnancies and so forth. So it's not without risk. And this is the beautiful page of recommendations for patients and those around them. And this is really important because nutrition is incredibly important. And this talks about iron being found in red meat, beans and nuts, B12, meat, fish, cheese or eggs. It talks about how to take iron and questions to ask. And it's a lovely, very simple recommendations page. And this isn't our guideline, this is from Canada, just talking about it states there, it takes the iron of 177 steaks to build a baby. And I found that quite shocking, actually. There's a huge amount of the iron is required. It's quite poorly absorbed in some people, and it is used and lost and affects not just blood, but a number of processes within the body. So for organisations, we basically want the haemoglobin early. They ought to appoint a clinical lead because that's a way of getting change, questioning data and so forth. And anaemia should be discussed in the transfusion committee meetings, and they should be educating. Now this is about patient blood management. And this is a slide from the World Health Organization, because it's not just about detecting anemia and treating it. It's also about, so that's pillar 1, it's about managing the anemia, but it's also the minimization of blood loss. And the third pillar is optimizing the patient's physiology. So it's about doing all of those things to try and get the best possible result, to try and reduce the number of people becoming anemic due to surgery and so forth. There is a definition of anemia, so it's different for children. It is slightly controversial in that the World Health Organization definition from about 50 years ago is lower for women But there is a new consensus. The international consensus definition is to have all genders the same for adults of 130, and that actually 120 is probably low for women. So that is, we've stated that it is an evolving field, that definition. So iron deficiency anemia is the common one. There's either increased losses or reduced supply, or both. And things like celiac disease reduces your ability to absorb iron from the diet, and post-bariatric surgery. And just to bear in mind, a lot of iron is recycled from senescent red blood cells. They change every 120 days, and the macrophages recycle the iron, but you still do need some from the diet. And then when we're measuring things, we need to know about the big proteins. So ferritin is an intracellular protein, in fact, that stores iron, but you measure the serum ferritin that's circulating. And if that's low, you've got iron deficiency anemia. But because it's an acute phase protein, it might be higher. And therefore, you need to look for other things, such as this percentage saturation of transferrin, which is the transfer protein. And again, if that's lower than 20%, that suggests absolute iron deficiency. And the other big protein that's quite interesting is Herceptin, and that basically, if that's stimulated, it prevents the absorption or recycling of iron. So if you're taking iron tablets too frequently, that will stimulate Herceptin, which stops you absorbing iron. So the next type is functional iron deficiency, also known as the anemia of chronic disease or the anemia of inflammation. And again, it can be quite difficult to measure, as I mentioned, with the ferritin can be artificially high. But because you've got high absorption of iron, and it's common, particularly in chronic kidney disease. B12 deficiency is also very common, 20% of the over 65s in the UK. It's actually very difficult to get in a vegan diet, and many supplements are actually quite poor. And the other thing is, because it's not widely recognised and the test isn't particularly good, lots of people present with symptoms that actually might be caused by vitamin B12 deficiency rather than the surgical problem. And there are rarer causes, and the haematology departments are very keen to have patients referred. So the pre-assessment, there should be algorithms, and do consider, because it might be, for example, a gastrointestinal cancer that's causing an anemia. So people need to be treated and investigated. And in fact, a pharmacist can give a patient iron without requiring a prescription. So there are we've standardized in the guideline the tests, so everyone with a new low hemoglobin gets all of those tests, including the CRP, to see if they've got an inflammatory process going on. And then if there's an indication, they get some of the other tests, like for celiac disease, if celiac disease might be likely. And then this is the algorithm, and in the bold text is what you're looking for. So iron deficiency anemia, or functional iron deficiency, or a bit of both, or B12 deficiency, or other things. And the critical things is the ferritin low, is the TSAT low, and that sort of thing. So you just work through the algorithms, and then the nurses can do that. And the boxes on the left are those tests that I said, the ones that everyone should get, and then the ones if indicated. And sorry, that also says what to do about it. So if there's time, you then want to give oral iron, and it starts working within 4 weeks. But the dose is quite critical, and what we're suggesting is a daily dose of 1 tablet. This is different from what's in the BNF that still says, let's say, 3 tablets a day, but that switches on the Herceptin, and then you don't absorb the next day's dose. So a daily dose, or even an alternate day dose, would be better. And that also reduces the side effects, because of some of the side effects, such as nasty diarrhea, for example, are because of unabsorbed iron within the gastrointestinal tract. Just a plug for the UK Clinical Pharmacy Association guidance on the Peroptive handbook, medicines around the time of surgery, and that's absolutely brilliant, because you want to make sure anticoagulants are managed so people don't lose too much blood through bleeding from the operation. And this is a summary of types of anemia, and then the causes, because they can be different for everybody. So we've talked about the functional iron deficiency, the B12 deficiency and so forth. And just to say, the British Society of Gastroenterology is actually keen to have patients referred if they've got a newly diagnosed iron deficiency anemia, if they're men or postmenopausal women, because many will have gastrointestinal pathology. A third of them will have gastrointestinal pathology, and they should consider gastroscopy and colonoscopy. And obviously in elderly people or people with other things going on, that you have the risks and benefits of how invasive you investigate, but that's a shared decision-making discussion. But they do want people referred. As I said, risks for anemia are more complications, slower rehab, increased length of stay, more return to theatre, feeling a bit woozy when you stand up, so the physio has to come back the next day, that sort of thing. And we need some shared decision making, so the patient knows the benefits, the risks, the alternatives, and what if we do nothing, both for the treatment that's planned and for the investigation perhaps, and for getting ready for surgery, and what the alternatives are. And we want kind of the two main groups of patients. There's the standardized groups, and that should be risk stratification by the nurses into should they be optimized, protocolized, bringing all those steps earlier, getting the diagnosis earlier, getting the treatment started earlier, anticipating stuff. Or if they've got complex stuff, particularly when a result is available, and a senior clinician should be available to do the complex decision making. So this is just kind of what are we thinking, because when you want to individualize it, have you got all the test results? What's causing it? What should you be doing? What should you be doing a different sort of surgery or postponing it to get the treatment right? So that bit needs to be individualized when it's complex. As I say, there's a finite number of interventions that are possible. IV iron, there are two main types that are used when required. And they can work quite quickly, but the PREVENT trial didn't show a reduction in blood transfusion given, but it did show a higher post-operative hemoglobin. Then intraoperatively, there's quite a lot going on. Tranexamic acid should be used for surgery with that is potentially causing major blood loss, weighing of swabs, and just a mentioning of the patient blood management plan using the HUE checklist. This was just in Twitter at the weekend. If you're not routinely using tranexamic acid in surgery, why not? That's the UK Royal College's tranexamic acid working group. And we've even got a thing for children in the guideline. So we also want restricted transfusion triggers, unless obviously you individualize it for certain patients, but each unit should be considered carefully. We got a bit about pregnancy, because 25% of pregnant people will experience anemia, and 31% of babies are delivered by cesarean section. So it is an operation in a number of cases. And there's an effect on the baby and the mother. And it does have quite a big effect on brain development for the baby, and also the mother not bonding quite so well or feeling tired and so forth. So these are, we've again amalgamated other guidelines, so people get the checks, they get the treatment, and so forth. In children, it can be quite common, between 24 and 32% before big operations. And tranexamic acid should be considered in children during big operations. And again, there's some algorithms for children, whether it's iron deficiency, anemia, or less likely, or a thalassemia or another similar problem. So basically in the guideline, there are lots of boxes like this of what should be considered at each stage by different people. So you might have a point of care testing in the outpatient clinic, for example, so that decision's made earlier. Whenever you're trying to change anything, you've got the early adopters. We actually don't need that many people to make a difference, because the other people take a while to change. We've got loads of guidance. Do go to cpoc.org.uk, find all the other stuff about diabetes, frailty, enhanced preoperative care, and day surgery. Preoperative care really is better for patients, better for cost, better for efficiency, better staff, because you know you're doing the right thing and you're working together as a team. We've got the NATSIPS, National Safety Standards for Invasive Procedures, coming out next month. Do look for them. We need your help, because that's about the HUE checklist, about making things standardized and reducing errors. So what can you do? Sign up for the CPOC newsletter, tell everybody about it. And in summary, anemia is detecting early, rearrange your pathway so you detect early, find the type, find the cause, do the treatment, and think about patient blood management. And do follow us on Twitter at CPOC @Pre-Operative_News. Thank you very much.
Thanks so much, Scarlett, for introducing the guideline and pulling out the key features really for us all to be aware of. That was great. I'm going to hand straight over to Lawrence, who is our patient board representative at CPOC, and to really give us a patient view on the guideline and the kinds of things that you may want to reflect on when we're chatting to patients in the various settings that we do chat to patients in. Thanks, Lawrence.
Very good evening, everybody. I hope you're all well. My background is actually in healthcare as a dentist for 40 years prior to taking retirement. And 6 years ago, I needed major operation myself for cancer, and so found myself swapping my hat as a clinician for that of a patient. And from that experience and from the many other conversations I have each week, I recognize the need for the patient voice to not only be heard, but amplified appropriately, as well as the need for patients to be given permission to ask the right questions at the right time to help them choose the right options for their treatment, which is a little less controversial than saying empowering patients. In my current roles, I come across a wide range of patients and public, as well as clinicians. And increasingly, the patients that I speak to have many more complex medical combinations, which I've started to understand means that the potential is there for poorer outcomes following surgery. And that the quality of life that a lot of these patients are expecting may actually be a lot less than the patient was told or they were actually expecting. And with the increasing waiting lists, the expansion of surgical hubs, little but significant issues may be missed or misunderstood. And I suppose for me, one of the issues that I regularly hear from patients about is anemia. Not necessarily the condition per se, but the ramifications when it's missed or not treated in a timely fashion, because it leads to delay in an operation. It leads to increased anxiety and worry for patients and the carers and the family who are looking after that particular person. There's many reasons that I love this guideline, and I'm actually quite passionate about it as a patient representative, primarily because I see firsthand just how beneficial it would be for those patients whose complexities are the greatest. Those who will be the most likely as well to have anemia as a presenting factor, often without their knowledge, which could compromise the quality of their outcomes even before they contemplate making decisions and choices on their treatments. And I can say that objectively, as apart from reading some of the drafts over the last couple of months, I haven't actually been involved with the governance body behind this guidance, who have put such a lot of work into writing it. So I can stand back and I can see this as a mature, authoritative and comprehensive overview of everything good about collaborative working, and particularly having public and patients right at the centre of its development and production. Perhaps I can just give a very simple example based on a real patient story that I've been involved with very recently, to look at some of the areas that illustrate the importance of this guideline at different stages in the patient's perioperative journey. I want to look at a switched on process. So let me introduce you to Ethel. You'll probably guess from the name, she's a slightly older lady. She's 83 years old. She's been cared for by her husband in recent years as her health has just gradually and slowly declined. They're both of a generation that don't want to bother the doctor, because they've read in their Daily Mail that they are incredibly busy people. And guess what? They can't work out how to do the morning appointments by phone anyway. She said this to me: it's confusing to understand what option one is when you've listened to 5 options. And then she said, and then when you get through, you find that you're number 16 in the queue and you need to go to the loo. these are the sort of the day-to-day happenings that our patient needs to deal with. They'd left it a bit too long. She is now frail, she's undernourished, she's underweight, and for the past 3 weeks, she's been bedridden. She needs an emergency ambulance to get her to hospital, where she's diagnosed very quickly with a likely diagnosis of bowel cancer. So can you see that her perioperative journey is well underway, even before the blood tests arrive? And of course, on top of all those challenges, the blood tests show that her HB levels are incredibly low. Now, in this example, which is a hospital near me, they already have a perioperative lead who is well versed in whole patient care, and particularly in anemia management. There's great communication between the clinicians and the patient and her husband. They lay out the diagnosis and a pathway approach to treatment, with appropriate, I think, emphasis on iron deficiency and how it will need to be dealt with. But also the more important stuff for her going forward: nutritional advice, mobility encouragement, general building up of any shared decision-making decisions before the process needs to be made before she decides on a cancer operation. So anemia for this patient is vitally important. It's a really big factor. It's central to many other considerations. This needs to be sorted out first and foremost, and it needs to be addressed at every stage of the perioperative journey that this patient is going to go on. And it also emphasizes just how important it is to have a recognized perioperative pathway in operation that the trust can understand and they can value, as well as the importance of having someone who acts as a champion for perioperative care and can take the patient through the whole process. Now, I'd love to tell you that that experience is quite a regular experience that I come across. I'm sorry to say it's not the norm. And sadly, I hear lots of stories of patients, often on very long waiting lists now, who arrive for major surgery, for example, who are now classed as anemic, even though they weren't when their initial bloods were taken. And the fact that this seems to come as a surprise to many and delays operations and raises anxieties doesn't seem to be being addressed quite as well as I think it should be from the many stories that I'm hearing. I also hear of the wasted opportunities while patients are waiting for surgery, where improvements in health could have been made to get the patient in full fitness before an operation and to correct anemia early. Such a common condition in the population of patients that require the complex surgery in older life that we often see. To me, it seems such an easy win. And I'm actually amazed that perhaps we should be talking about a new guideline, but let's face it, that's life. What I like in this guideline is that it pulls everything together. There is a specific patient-focused landmark all the way through every stage of the journey through a hospital. And if it could be implemented in all trusts, do you know, it would make the most enormous improvement in the treatment of patients. And many of the stages that Scarlett was alluding to earlier are actually quite obvious and quite simple, almost to the extent that they're embarrassing. But isn't it great that here is a guidance that brings them all together for a patient, knowing that it's helpfully patient-led through its development, to give a comprehensive overview of patient care. And it looks at things, when I read it, as nutrition being a key factor in anemia. There are many people out there who, patient-based and general public-based, don't actually understand that even in this day and age. And with the economic downturn that we find ourselves, this is going to be increasingly important as people make a decision about food, transport, lighting, heating. I love the way it highlights early diagnosis and early treatment for anemia, both the cause of anemia and to boost the blood results as a key factor. There are so many talks in there about different types of iron. Have you ever tried to take oral iron? Hands up if you have. It's an interesting journey. I've been down that journey rather than having just a vitamin mineral supplement. There are so many good things in here that focus on good patient care. So I suppose in summary, I highly recommend everybody reads this guidance and actually shares it with patient groups and lay representation, because it actually gets to the heart of anemia. And more importantly, I suppose, I can see just how radical it can be to enhance a patient's care. Perhaps I can leave you with this as a final thought. Anemia isn't a new condition. There are archaeological evidences that show skeletons 4,000 years ago in a site in Thailand that shows it's been around for quite a little while. You know, as a patient representative, I think it's time, perhaps overdue time, to remove any uncertainty on how anemia really impacts on a patient's perioperative journey. And I have to say, I think this guideline is a gigantic leap in the right direction. Thank you to all those who've put it together. It's quite a brilliant thing to do. Thank you all.
Oh, thank you very much, Lawrence. So kind of really building in the patient perspective, having reflected on the guideline summarised by Scarlett. So we're going to move straight on to hearing from Steve, who was our fellow on CPOC until the summer, but and we're continuing to make sure that we're working with him. And he's back into his training as an ST7 down at in Royal Devon. But really starting to think about kind of some of the challenges maybe that occur when you see this guideline land on your doorstep and you think, okay, what am I actually going to do now with trying to think about this, implement it, and some of the thoughts that might be going through a lot of people's heads at this stage. So over to you, Steve. Thank you.
Thank you very much, Jagdeep. So hello and good evening, everyone. My name is Steve Evans, and I'm currently an anaesthetic ST7 in the southwest of England. And I was the Centre of Peroptive Care Fellow from August of 2021 until August of 2022. And I've been part of the working group for the Anemia Guideline. And this has provided me with a huge amount of insight and experience with guideline development and working with such a large multidisciplinary expert panel. And as I'm now approaching my CCT, this has given me the knowledge and insight into the many barriers and enablers into service development. I don't have the answers to the perfect implementation strategy, and I'll be spending the next 5 to 10 minutes talking about some of the implementation issues with the aim of generating some ideas and thoughts from you, of the attendees of this webinar, and those who are thinking about developing a service, or those who already have an established service, about how we can share the same ideas. So clinical guidelines are valuable tools to improve patient safety and increase knowledge, with all of the aim to improve clinical outcomes. And these are often based on best evidence to support clinical decision making and are essential for planning, delivering and improving high quality healthcare. But they often take a long time to devise, and putting them into practice can be challenging. I think it's fair to say that implementation is difficult, and it's for a number of reasons. There are often multiple personnel involved, and we all like to think that we go into meetings believing that we're all mates and want to achieve the same outcome, but often it just feels a little bit like a tug of war. There is no doubt there are local, regional and national priorities which all have competing interests. I'm sure we all start out with huge amounts of enthusiasm and believe that we can change the world, but again, it's fair to say that the current workforce is quite tired and feeling generally fed up and a bit demotivated. And trying to regain that focus and enthusiasm will take some time and effort. And when trying to start a service, I'm sure that this is what we all envisage. Bucket loads of cash to kickstart the process and try and maintain the growth of the service delivery. However, the purse strings are currently pulled quite tight, and generally what's on offer is quite slim pickings. And sometimes it feels that all we're trying to do is push a rock up a hill. However, I believe it's not all doom and gloom, and that the NHS does have a remarkable way of making do and mend, and we will often find ways to work smarter and be more efficient. I performed a brief kind of literature review to see what any evidence is out there surrounding guideline development. And these are a few articles which I found. The first in the top left is an article in the BMJ from 2004, which looks into some of the evidence surrounding NICE guidance implementation. The second on the middle right is from 2012. It looks into 3 implementation interventions. And the third on the bottom left is from 2001, which looks into some of the successes and failures of implementation guidelines. They're quite old articles with slightly scanty evidence, but in a nutshell, what they do is help to reiterate what we already know. Like, guideline implementation is difficult and can be slow to uptake, but where they are successful, it's down to motivated and enthusiastic groups of individuals who help to push the agenda and keep the momentum going. So, taking into account what we already know, in combination with some of the reports from the literature, I found that some of the biggest barriers to guideline implementation can be quickly turned into easy wins. And some of the biggest barriers are down to lack of awareness and lack of familiarity. So lack of awareness can be easily won by dissemination. So that's what we've done at CPOC, mass media, through social media, and emailing out a large proportion of some of the peroperative leads within the hospitals. What I've done in my own institution is emailed out my department, not just within the anaesthetic department, within the surgical department, the medical department, and the haematology department. And monthly kind of audit meetings or continuing medical education, these should be kind of promoted, and maybe using specialty specific training days. So, for example, obstetric anaesthesia or pediatrics or surgery. And it's really important to engage all of the stakeholders within this, not just within your familiar department. Specific guideline focus, so using kind of bite-sized chunks to enable a bit more of a tailored approach can help with some of the easy wins. The attitudes of healthcare professionals, including a lack of agreement amongst specialists, can be a significant barrier. It can be both extremely rewarding and hard work to collaborate with departments within your institutions, and this may mean multiple email exchanges or face-to-face meetings. So, for example, meeting with clinical leads of haematology, medicine, surgery, maybe agreeing automatic add-on tests with the laboratory technicians, involving nursing staff and showing them why preoperative anemia testing and subsequent treatment is important. It's also important to note that this is a living document, which means that new versions and updates can be released depending upon new and evolving evidence. Quality improvement projects, so using the standards of care within the guideline and recommendations, can help within, so for example, trainees within departments can use these to improve the current services within the departments. And knowledge and skills can be enhanced through local, regional teaching days and the monthly audit meetings or continuing medical education. The longer term can be a little bit more difficult because this is often over many years. And there is a possibility that changes to hospital organisation and structure can be achieved. And it's a bit like trying to fit all of the pieces of the jigsaw puzzle back together again. Resource management will always be a challenge, and deciding where to invest for service and operational development will be an ongoing battle, particularly at the moment with the elective recovery backlog, which is a priority for government, trusts, managers and clinicians. This does, however, the guideline that is, fits into the workload and can improve patient outcomes and aim to reduce overall lengths of stay. So in summary, guideline implementation is difficult, but with a motivated workforce, a motivated group of individuals, it can be done. It does require drive and motivation. We would like to hear from you, the attendees of this group, and see how it can be done and where it can be improved. And overall, this guideline can improve patient outcomes. Thank you very much for listening.
Thank you very much, Steve. So we're going to just invite the panel back now to answer some of the questions which have been being posed in the Q&A. some of which we have already started answering in the chat as well. So hopefully, but if there's further discussion to be had about those, then please do make further comments there in the chat. So just kind of looking through those, I think some of the kind of maybe where we could start is Scarlett kind of maybe thinking about this issue around an HB of 130, and is that really a target or is it a trigger? And kind of your thoughts about that.
Thank you. It's really the definition, but everything has to be a little bit balanced. So if somebody's got a hemoglobin of 125, you wouldn't want to delay their surgery to treat it. But if they've got a hemoglobin of 90, then maybe you would. So it's individualizing it to the patient, but being aware that below 130 is defined as anemia, and the patient is therefore not at their optimal physiological state. Thanks.
Thank you, Scarlett. And I think kind of maybe that is a really nice way of framing it, in that it is a trigger for us to start thinking differently once it's less than 130, and start to kind of realize that actually it's at that point that we know that people have worse outcomes, and therefore we need to think about, you know, what level is it, what are the possible underlying causes, and triggering us to go down that usual medical path of history, examination, investigations accordingly. So I think maybe that is something that doesn't come across kind of as clearly as we could maybe have it in kind of further versions of our guidelines, is the difference between a target and a trigger. I mean, I don't think we're ever going to get the whole population up to 130, are we, in surgical settings? So that's a really nice kind of a pick up there for us. So thank you. And I think that also kind of really reflects on the fact that we do want these guidelines at CPOC to be living documents. You know, we're not waiting for 3 years before we do an updated version. We can change these as we go along to adapt to the literature as it emerges, but also to this kind of constructive feedback that we receive from our perioperative teams across the country. So thank you for that. Another question there kind of very much kind of relates, you know, of course, to implementation of guidelines, as Steve and Lawrence, you've kind of mentioned as well. But, you know, I think we all are tired of having guidelines suddenly arrive and then thinking, well, what do we actually do with this? And Steve, you've given some really good pointers there. But Lawrence, what do you think is the role of patients in supporting implementation? And how could some of our clinical teams engage with the patients and the public to be able to implement their guidelines on the shop floor?
Yeah, it's really at the nub of everything, isn't it? So if I give you the example of a clinician, the best way that I've seen guidelines implemented within hospital situations is by one really keen clinician who really is passionate about something, being able to build relationships with all his colleagues and driving something through to the extent that everybody understands why it's really, really important. I'm sure yourselves and everybody on this course has come alongside that. So in many ways, it actually needs really passionate patients as well. Wouldn't it be great to actually have a patient representative on every trust board who actually had some overview of perioperative care? I think that would be a really sensible approach. And I'm not talking about an expert patient. I'm talking about somebody who understands what it's like to be a patient, to actually understand the pros and cons of it. And maybe every trust really could dip into what a fantastic lay representation already that's actually available. But I think it comes down in the same way to clinicians of having somebody who understands why anemia is important, why perioperative care is important, why diabetes is important, and be able to be the flag waver for that in a way that actually sees change taking place, and also allowing them to have enough time for that change to be put into operation.
And I think that probably makes lots of us in the audience smile, doesn't it? Kind of the time factor, which is such a big issue for clinicians from all disciplines at the moment, as to how do we create time when we are so short on the workforce and all of the other challenges that exist post pandemic and everything else? But there probably is something about clever use of time, isn't there? And Steve, I don't know whether you had any reflections on that as kind of coming up to end of training and using time more effectively to illustrate these kinds of stories.
Yeah, so my previous institution where I worked actually were in the process of evolving their preoperative anemia service. And one thing which kind of caught my eye was doing a point of care test for patients who come in, who arrive into clinic, and if found to be anemic on the point of care test, then blood test would be taken, sent to the laboratory urgently with the ferritin, the B12, the folate, the iron studies, and if found to be iron deficient anemia, can then effectively go to a next door room and have their iron infusion there and then. So avoiding wasting time for the patient, because it's annoying for patients to come to hospital, to find somewhere to park, to find the room that they're supposed to be in. If they could effectively have a bit of a one-stop shop in a way and have all of their tests done in one go and then be sent off with the treatment, surely that's better for the patient, it's better for the service, and it's better for the hospital overall, really. So this is partly what I alluded to in my presentation about finding smarter ways of working, because the NHS at the moment is a very difficult place to work, and we all know that, but it's finding new ways of working without trying to reinvent the wheel, really.
I'm not sure if you can still hear me. Can you hear me okay? Yeah. Okay. Yeah, no, that's really key, isn't it? And that also kind of links in with one of the comments kind of put in the chat as well about kind of performing the right tests at the right time. Jessica's just put that there as well about getting the lab to include the right tests early in the pathway. And that's certainly something that we ought to be talking to our local labs about how we get that embedded. And Scarlett, I think, that is the key, isn't it? Is kind of starting this as early in the pathway as possible. So I can imagine that a lot of our 100 participants this evening are predominantly anaesthetists, I should expect, or anaesthetic kind of department colleagues. But what do you think the role of the surgeons is in getting this embedded early in the pathway?
Thank you. I think it's about telling patients or having some way of identifying who is anemic early on, so we can use the waiting list as a preparation list. And some people really have very poor diets, and it's not all about the expensive buying steak or something. It is about the green leafy vegetables for folate. It's all the other things that actually do make a difference. So it's about having a system of being able to get the patient optimized. The pre-operative assessment in some services is too late. It's seen as something that you get given a date for surgery and a date for a pre-op assessment just a couple of weeks before, where things are written down but not acted upon. So we need to get people earlier. Basically, we need to make the diagnosis earlier and do that battery of tests to find out exactly what sort of anemia it is, and then what's causing it, and then planning from there. So, I mean, as a surgeon, I get lots of emails just before the operation saying, oh, we've had this result in, shall we operate? Shall we go ahead? What should we do? And as a surgeon, it's all the HbA1c or someone's BMI or whatever it is, and in this case, anemia. And I'm always kind of actually, well, they've got their date, let's carry on and do it. Well, that's my instinct to do. And it just seems such a wasted opportunity that, if we could possibly have got that information earlier, even back at the GP stage, that would be so much better. Thanks.
Thank you, Scarlett. We've got that comment there in the chat there about surgical teams initiating tests early in the pathway. And I think, that is kind of our the ethos really through CPOC is trying to engage the whole of the perioperative team in this, that this isn't one kind of person's responsibility, but it is ensuring that things happen at the right time along the pathway. But at the same time, that does raise the issue around responsibility, doesn't it? As to, we often have this conversation about whether this is something that the GPs should be picking up and managing, or is it something that is secondary care's issue because we're performing perioperative care and therefore it's something that we ought to be looking after. So Steve, any kind of thoughts on kind of that, the cross-boundary working between primary and secondary care in this situation?
Yeah, this is a really interesting topic actually, because there is no real right or wrong answer. The GPs are extremely busy, as we all know, and bouncing tests back to the GP, on the discharge summary, just refer back to GP for, it's frustrating, and I'm sure it's annoying for our GP colleagues. If the patient's in a hospital that can perform tests rapidly and you can get everything that you want in a hospital, then you could argue that why not do it in a hospital setting? But who's ultimately responsible is a very interesting issue, really. Traditionally, the model is that the surgeon is responsible, because ultimately that's where the discussions often takes place. But an interesting question back is, should just the surgeon be the person deciding to operate? Or, with my rose-tinted glasses on, in 5-10 years' time, will we have perioperative specialists or physicians who are ultimately responsible for patients throughout their entire perioperative pathway? So that still hasn't really been sorted out. And at the moment, I think this traditional model is still going to continue. But if we collectively, as a body and as clinicians, can just move some of this early on in the pathway, I think I can see that as a success over the next few years.
Thanks, Steve. And there is a comment from Lisa as well about the work being done with primary care to engage with the guideline and be involved in optimization. So yes, Lisa, we are working with primary care at the moment. We've just started up a new piece of work at CPOC, looking at the interface between primary and secondary care and how we can improve the work that needs to be done for our patients, and making sure that that communication works better, and that we do kind of have clearer lines of responsibility, but some of that responsibility also sitting with patients, with primary care and then with secondary care. And those are all the kind of the nitty-gritty bits, aren't they, which are often difficult to tease out, but hopefully with some good case studies from around the country where this is being done well, that gives people an idea of how they could potentially approach it locally. So do have a look at the CPOC website as well for case studies that illustrate ways in which this can be done well. Lawrence, other kind of ideas about how we support patients to be able to support their GPs to engage with this work? How can patients kind of communicate back with their GPs and get them engaged?
One quite exciting thing which I've been involved with recently is this new development of patient participation groups, which I think could actually be quite a key way of actually getting change through. They're still in their infancy. My local practice, for example, has only started one up in June this year, but they are another springboard to actually be there on the front line with GPs. And I would agree with you that they are very overworked. And I think there's this difficulty with any part of a profession that says, goodness me, that means a lot more work for me. And I think that's often been my reaction when I've been a clinician. But actually, when you step back and you look at the bigger picture of getting things right at the start, it actually leads to a much better way of working if you can only get into that. So certainly for me, it's an area that I'm starting to branch into for patient participation groups. And I hope they actually do develop more and more within the practices. But also, just to point out, and probably many people know this already, but one of the board members for CPOC is the Royal College of General Practitioners. So they have the opportunity of not only helping with the guidance development, but hopefully being able to show it to their members in a way that actually is very, very beneficial. So hopefully it's not a scary thing of yet another guidance. It should be something which the professionals really back very, very strongly, because they can then see the benefits that actually come from it.
Thanks, Lawrence. So there are quite a lot of kind of questions and comments around kind of at what point in the pathway should what happen and what's CPOC doing about that. So yes, there's the primary secondary care interface work going on, in which we are looking at the referral pathway, what should happen prior to referral for a surgical consult, what information should flow in, and how that information can flow in more consistently. So work certainly going on at NHS England by the Periop team there, that we're also linking in from CPOC as well. So we've got that kind of bit around kind of GPs kind of maybe checking. We've got that bit about kind of surgical teams trying to get those tests off early in the pathway. And then we've got the issue about who actually should look at these results. And that's a number of the other questions there as to what, who should look at the HB levels when we're trying to look for diagnoses and then treat people. So I don't know, Steve, Scarlett, any kind of comments on kind of who is the right person to be looking at this? Or shall I take it? Go on, Steve.
I was gonna, well, I've always been, my practice has always been the person that's, ordered the tests, ideally should be the responsible person that's checking the test. However, it doesn't always work that way. And what often happens is, ultimately when a patient, for example, arrives in a pre-assessment a week or days before their major operation, or even, in the anaesthetic room, you're checking blood tests, for example, it can be frustrating to find these late when something could have been done earlier in the process. Who should be responsible? I guess, again, the traditional model is that, a patient will have a responsible clinician in the hospital, which it could be them, but ultimately the person who is operating or is going to be responsible then post-operatively maybe could be the one that's checking. But open up to other topics of discussion.
Yeah, and it is a real area for debate at the moment, isn't it? Because of course, knowledge around causes of anemia, treatments, what should we expect prior to surgery, may be out with some of our surgical colleagues' kind of knowledge and skills in the way that the curricula have developed so far. And I think that really then comes back to this whole issue around perioperative medicine. And what's becoming really clear is that we do need new approaches to this. We need clinical services that can provide this holistic approach to diagnosis, assessment, and optimization. And that may require a different skill set to what we've traditionally had sitting within anesthesia, surgery, or within medicine. And that probably kind of, very nicely leads into some of the work that Scarlett's just about to start with Health Education England on behalf of CPOC and with all of us, looking at a curriculum for perioperative medicine and then developing appropriate education and training. I don't know if you want to mention anything about that very briefly, Scarlett.
Thank you. I mean, the problem is we all kind of learn in silos and we work in silos and we experience what our seniors and colleagues and trainers do. And so the curriculum that we're going to be designing over the next 18 months is across the whole pathway. So some people will be really good at one section, but actually need some sort of top-up training in another section they might not know about, including things like post-operative rehabilitation, because if we can get that in earlier, then people are, then the patients can get out of bed sooner, people can practice earlier. So yeah, it's that win-win again. If we can get different members of staff being able to deliver some of those kind of crucial bits of care at the right time, we get a better service.
Thank you, Scarlett. So we're pretty much running out of time. We've just gone past 7:30. There are a few outstanding questions there in the Q&A, so we will try to answer those between us and post some answers online. But it just really remains for me to say thank you to all three of our speakers and to the audience, particularly for posing lots of questions, because that's what always makes these sessions more interesting. So thank you very much. We will be putting together a slide set and sharing that with everybody so that you can then use those slides when talking to local colleagues and trying to influence the models of care that are starting up in your centres. We'd also really welcome your constructive criticism, feedback on our guideline, because as I've said, we really do want to make this into a proper living document that we update according to what the needs of the audience are. We'll also be posting a feedback survey after this meeting, and again that will help us not only with this guideline but any of the future guidelines that we are developing at CPOC. So again, please do provide your thoughts on that. So thank you very much everybody, and I hope everyone has a nice evening. Thank you.
Thanks very much.